let's start the part two of biometry. In this part two, I will going to talk about basically formulas and how we are going to use these formulas. Okay, so let's move forward. So in case of biometry, the measurement of dimension of eye. So what are the common dimensions according to Wolf anatomy? Its common dimension ACD chamber depth is from 2.6 to 4.4 mm on an average 3.1 mm, isn't it? So basically, anterior chamber depth increases as the age is and decreases even after when lens becomes swelled, or lens not swelled basically, but lens become larger. So less than 20 years, lens thickness is 3.5 to 4 mm. Up to 50 years is 4 mm, and up to 90 years, then it grows. Okay, so 4.75. So Vitis chamber depth approximately 6. In adult eye 16.5 mm. Axial length, external and internal. Actually, external means the average is moreover. So it's very roughly varied between races and between many things matter. Okay, so let it be. We always take 24 as a rough idea. So biometry, so angle closure basically means whenever we think about biometry, we always think about angle closure glaucoma, because shorter the eye, it will create chances of angle closure glaucoma, isn't it? So what are the things that basically in correlation with glaucoma, basically biometry? So reduced axial anterior chamber depth, it's very crucial, isn't it? Thicker lens, higher chances of angle closure glaucoma. Shorter axial length, definitely higher. Steeper radii of curvature. These are the four things that are very highly correlated with the angle closure glaucoma. So let it be. Then let's move forward with the IL power calculation. So based on the three variable, I have already talked about it: corneal power and axial length, and the distance of IOL from cornea and the retina. Basically, what it means, the here is the IOL, let's say, and the distance between these two, the cornea and lens distance between these two, that both matters, especially these two, because cornea and IOL both are optical element, and the distance between optical elements matters. So empirical IL power determination based on the regression analysis of the actual post-operative result of implant power as a function of variable of corneal power and axial length. This is the formula, isn't it? This very famous formula: A minus B into axial length in millimeter minus C into average corneal power in diopter, where P is a power of IL power, and ABC as a constant for a given uh, IL power. Means it's uh, definitely not for human to human, it's basically difference, but but a particular given intraocular power is constant. So simplified by making the constants B and C stands for the all lens designs, and A alone changing according to the lens style used. I'll definitely going to talk about what is a constant. What is a constant? Obviously, we know that B is some constant, C is some constant, and axial length is differ, and corneal power is differ each person. But yes, what is A alone changing. B and C, and we will definitely talk about this SRK formula. What is B and C? What is 2.5, 0.9, and whatever. But I want to talk about the A alone. What are basically many students have a wrong concept about A constant. Okay, so that's why I want to talk about A. So the A constant depend on the several factors. These are the very important four factors I am talking. A constant depend upon IL material, where you are using A constant, the actually position of IL and type of IL, basically ACIL, PCIL, and position and the material made on, whether it's PMMA or other things. Okay. Second is surgeon factors, which means the technique of incision, placement of the incision. It matters. Okay. Third factor, K and axial length measurement adjustment factor, which is we will definitely talk about SRK second. So fourth, adjustment of the manner of carrying out the biometry. It also depends upon that. Okay, there are four factors that depend upon A constant. That's why A constant is sometimes is it constant, or yes, it's constant for a particular IL and particular surgical technique. So once fixed for the particular surgeon, IOL and the scanning device, A constant applied for the constant appropriate IOL formula. So If one surgeon IOL and scan device is fixed, then definitely a constant is a constant. So a constant variable, this is very useful. Whenever you change a constant by 1, change in IOL power by 1. It's very simple. Okay, this is the relation 1 is to 1. Basically means if you change a constant from 180 to 190, if IOL 1 in 180 is 21, then it becomes, sorry, 190, then it becomes 22. If you change 1 from a constant, then IOL power change in 1, basically increases and decreases in the same fashion. Okay, this 1 is to 1, you have to remember it. And then gain, so what is this? The gain I am putting here because a lot of students don't follow the concept of gain. Basically, what is gain? Gain is defined as electronic amplification factor of the sound wave received by the transducer. Basically, what is transducer? Receiving that electronic magnification factors, that sound wave, and basically gain the return, isn't it? Gain in decibel. So normal setting around, what we do, 70 to 75 decibel percent. But this may not increase in the situation, this may be increase in the situation where high echoes are inadequate. So basically, in case of hard cataract, in case of dense ocular opacities or high myopia, we have to increase the gain. But at the same time, gain is decreased when the artifact is seen near the retinal spikes. Perfect example are silicon filled eyes and eye with pseudophakic. In that particular case, we decrease the gain. So it's very important to understand gain, normal setting of gain, and when we should increase the gain and when we should decrease the gain. Okay, it's important whenever you are trying to do actually find out the axial length by basic ultrasonography. So this is the main formula, isn't it? SRK, Sanders, Redchalf, and Kraft. Basically, these are three scientists. SRK formula. So SRK formula is very hit formula, isn't it? So IR power is A minus 2.5 axial length minus 0.9 average keratometry. Why average keratometry? I have already discussed about you. It's circle of least confusion. It's spherical equivalence. The predictability, the predictive ability of eye with the axial length of 22 to 24.5, 75% cases is accurate. So generally undercorrect short eyes and overcorrect eyes with a long axial length. In case of if SRK formula is used, it's better to use in 22 to 24 axial length. And if there is shorter eye, so generally it's undercorrect the shorter eyes and overcorrect the longer eyes. So it's undercorrect shorter eyes means it after after cataract surgery, patient will be hyperopic. Overcorrect long eyes means after refractive surgery, patient will be myopic. So that's why. So SRK formula is better whenever 22 to 24.5 axial length patients. So that's it. So I want to talk about it. It's very deeply. We see, we know it's A minus 2.5 axial length minus K. See, I want to divide this formula like this. A is positive, like 118, let's take an example. Otherwise, I can do this 0.9 K plus 2.5 L, isn't it? This whole thing will be minus with A, and whatever you get is power of IL. Then let's just think about it. If K increases, what happened? This whole thing increases. What do you mean by that? IL power decreases, isn't it? This L increases. What then? Then this whole thing increases, isn't it? The 0.9K plus 2.5 L increases, and at the same time power of IL decreases. And what about reverse? If K decreases, IL P increases, IL power increases. Axial length decreases, IL power increases, isn't it? Because A is always constant. Because this formula I can write this like this, isn't it? If I do minus here and then I can bracket it, it's like 0.9K plus 2.5 L. Then can we just say simply whenever you are doing your biometry, then what happened if you get patient with steeper K? Can you steeper K means one patient has 43, at the same time that patient has 45, another person. Can you say 45K means smaller IL power? If K increases, P decreases, IOL power decreases, isn't it? It's very simple. If K becomes flatter, let's take an example, K is 41. Then another thing is P decreases, isn't it? Yes. Simple. See, if K increases, P decreases. If K decreases, if keratometry value decreases, power increases, isn't it? Yes. Same time, same thing happens with axial length. If axial length increases, power decreases, isn't it? What do you mean by axial length increases? What do you mean by K increases? Isn't it very simple? If there is high K value, high K means isn't that patient is tend to be myopic? Yes, definitely. That's myopia means the correlation of K and axial length and obviously ACD. There are a lot of things. Just think about K. If K increases, myopia. If K decreases, hyperopia. Just taking K into account, isn't it? If axial length increases, myopia. If axial length decreases, hyperopia. So isn't it simple? If K increases means myopia, then IOL power decreases. If axial length increases, IOL power decreases, isn't it? And another thing that you have to understand whenever you are in biometry doing IOL calculation, see, this is always positive. A is always positive. It's like 115 for some 118, 100. It's depending upon the company and a lot of things we have already discussed about. You have to understand this too, that if K increases, let's take an example. If K increases at the same time axial length also increases. What do you mean by that? Isn't it a balancing thing, or is it worse? It's definitely worse, isn't it? K increases, create myopia. Axial length increases, create myopia, and at the same time, it decreases axial length like rapid. Isn't it? Decreases IOL power by rapid, isn't it? So you have to understand like this. You have to take care of three things: what, how, keratometry, power, axial length, and the power of IOL plays with each other. It's very important how these three things plays with each other, and that's the beautiful thing you can do whenever you are in the biometry room and you are calculating IOL. It's very important at that particular point. So you remember that if K increases, what happens? If IOL axial length increases, what happens? If at the same time K increase and axial length decrease, what happens? Because it's balancing, isn't it? K increase and axial length decrease. If K is flatter and axial length is longer, isn't it? That's balancing, isn't it? That's balancing, quite balancing. So you have to understand these things. You have to understand that if one particular thing changes and another thing doesn't change, what happens? So you have to understand these things very very quickly, and you have to take into your brain so quickly in the tip of the tongue, so you understand everything whenever you are calculating. Okay, this is very important concept. You have to take into account and understand these things. Okay, so second generation, I have already told SRK second. So as what SRK second does is very simple. As the predicted IOL position or the effective lens position, which is very important, effective lens position is very important, changes with the axial length. The SRK second formula was developed to involve adding or subtracting IOL power from original SRK value depending on the length. It's basically SRK second means if axial length is something, then adding 1 to the power. It's like 22.22, 21 to 20.22. You add 1 to the its axial length is 22 to 21. Uh, it's like adding 2 to the calculator. If axial length is 20, less than 20, adding 3 to the calculator power. It's very simple. If axial length is greater than 24, then subtract 0.5 to the calculator. So that's SRK second. Okay. So SRK regression formula, which is basically SRK second, sometimes is changed with the, we can, so something like that, isn't it? If you change a, it's very simple. If less than 20, then you put a1 means a plus 3. So it's basically same thing, it's in a different manner. So third generation formula is, what is third generation? SRK by T, which is till date, it's very used. Olade one, which is very useful. Hofer key is very useful. So when Hofer Q is used, Hofer Q is more accurate eyes with less than 22 mm. It's very important. Hofer Q is very useful in short eyes. Olade one works best with between the 24 to 26 medium long. SRKT Still srqt is used for every eyes, almost every eyes, not shorter but um, larger than 24, but it's even more accurate with greater than 24 it's very long, it's useful in very long. Okay, what is the limitation? Prediction of effective lens position is based solely on the central corneal power and axial length by assuming that anterior and posterior segment of the eye are mostly proportional. So that's what is the great prediction here is effective lens position, ELP. And by the way, if you go to iWiki and that particular what do you call that particular paper, not paper but iWiki, what do you call that, it's paper, yes, paper maybe. If you go there, I'll tell you which one. And if you go there and if you try to find out which particular portions has majority effect on the errors, then you will find the effective lens position calculation that has a majority of error in biometry. So that's why effective lens position prediction is one of the great limitations in case of third generation formulas. But yes, but third generation formula work well as far as I can tell you. So fourth generation formulas is Haggis. So Haggis is superior to the previous formula for all eyes, and the three constant used in Haggis A naught, A1, and A3. So anterior for the anterior chamber, but limitations is patient's database of 200 cases containing a wide range of anterior axial lenses required for optimize the regression lens. But Haggis is definitely a good formula, and it's been using currently nowadays after refractive surgery cases, and there are a lot of things that you're using. So let's move forward. Biometric formula requirement, yes, we know these three things, isn't it? Axial length and keratometry best for SRKs, and AC depth yet matters a lot. So axial length measurement, there are four methods, isn't it? So basically four methods, but yes, nowadays it's greater than four because OCT is always there. So applanation by A scan, and A scan there is two method, isn't it? One is applanation method and another is immersion. Immersion we can do two things. One immersion with only A scan and immersion with A plus B scan, and another is partial coherence interferometry, which is basically in IL master. But yes, nowadays it's more like OCT. There is also OCT with combination of Simplon camera, and there are a lot of things going on, which is very good, isn't it? So ultrasonography measurement determined by the amount of time required sound pulse to travel from the ocular surface to the retina and to return back. So basically, it's the game of speed, isn't it? Speed and time. So speed of sound throughout the ocular media is variable. Definitely, it's variable because it depends on the refractive index. It depends on the density, isn't it? So commonly accepted valuable range is 1532 meter per second in aphakic eye. If it is phakic or cataract, it's 1550 meter per second. Yes, it's definitely different in silicon oil too, in vitreous chamber definitely. So applanation technique involves the actual contact between tip of the probe and the cornea and using tear film as a coupling agent, and causes corneal depression and shortening of the axial length. So I'll definitely tell you the difference between applanation and immersion, but let's go. So immersion technique is probe are coupled to the eye via fluid chamber. Is very important, and it's been by fluid chamber and better with the Pager shells. So that's the difference. See, I'll tell you the sir. I'll tell you very rapidly difference. Okay, probe contact, yes, it's directly contact in applanation method. No direct contact, but probe is placed in fluid chamber. You have Pager cells or uh, other cells. So coupling media in case of applanation it's directly tear film as a coupling, but in case of immersion it's saline or methyl cellulose in a shell as a coupling medium. Corneal compression causes the corneal depression, definitely in case of applanation, and which cause if cornea is indented, what is the great disadvantage that it was falsely predicted that axial length is short, so that's why IL power goes up. At the same time, immersion technique, no corneal compression are more accurate axial length, so that's why immersion technique axial length is more accurate. So ease of using, easier. It's definitely applanation is easier, quicker, and commonly used. At the same time, immersion is slightly more difficult, requires cells and fluid, and there are a lot of things to arrange. But in case of applanation, it's very easy. Patient comfort, because direct touch, that's why reflex steering there is a chance, and less comfort. At the same time, more comfortable in case of immersive technique. Accuracy, low accuracy due to the variable of corneal compression. If it's compressed, then short axial length would be the chance, but chances higher accuracy and reproducibility in case of immersion technique. Axial length measurement may be underestimated by roughly 0.2 to 3 mm, which is approximately one diopter error. So it's more reliable and consistent in case of immersion technique. Clinical use often used in routine measurement where the slight error is acceptable. So it's often done because it's easier and it's quite time is not time consuming, but preferred by premium IOL calculation, longer eye and shorter eye and post refractive surgery cases. Immersion technique is, but yes, we have to give it time, and uh, the practitioner must be very good. Okay, so errors in axial length measurement, inaccuracy. So basically, this inaccurate assumption and the speed of cataract size. It's very important. We have settings in our machine, so we have to see these things. Another is novice practitioner. Chances are high that we indent the cornea. It's very important, and that's why skill matters here. Improper equipment calibration, that's definitely the case. Failure to recognize appropriate pattern of echoes. I have already told you in my previous videos what are the patterns of the echoes, what difference if there is an anterior cornea and posterior, sorry, anterior lens and posterior lens spikes. What about the retinal spikes? What about the spikes from the fat on sclera? It really matters. The anatomical thickness of the retina may also causes the error in IL calculation. Yes, definitely. So partial coherence interferometry, definitely in case of IL master. Now IL master 7, that's very good. Based on 780 nanometer light and high precision, high resolution, non-contact biometric technique. Basically, it's non-contact. So there are formulas given in the now to into IL master 700. It's very good formulas there. So IL power calculations. This is the formulas, and quick and precise axial length, corneal curvature, anterior chamber depth. These are all given there. So that's good. Suitable candidates for IL master is nanophthalmos or extreme axial hyperopia, extreme axial myopia, uh, prior surgery of retinal detachment with silicon oil, pseudophakic or phakic IL. It's very good. Limitations are dense media. That's very great limitations because dense media, dense cataract, corneal opacity, mature brucent cataract, dense PSCC, vitreous hemorrhage. These are all cases, and unsteady non-fixing gaze, retinal detachment. These all cases are very difficult with uh, IL master. So in that particular case, we found that immersion technique, even applanation techniques are better. So AC depth calculation. So basically, for the calculation of phakic and secondary IOLs, the incorporate the Osline and Hollard's second formulas. These are new formulas, isn't it? As two variables formula were found in to lose accuracy in case of extreme axial length and corneal power. So these are the formulas that is used with AC depth calculations. So ACD for PCIL is distance between the anterior corneal surface and the anterior curvature of the crystalline lens. So ACD for the whole is second, and Osland formula is distance between the posterior corneal surface and the anterior curvature of the lens. So these are the slight different concept. It's just the anterior cornea to the posterior cornea. Okay. In case of pediatric, I'm just going grossly again, not very deeply. In case of pediatric cataract, the more complex than the adults, obviously, and usually with the patient under general anesthesia, the patient being child. Shorter axial length causes greater IOL power error, definitely. Small eye cells in the child eye. So appropriate target IOL power on that will not only be provide adequate visual acuity or to prevent amblyopia, but also allow the adequate vision in adulthood. It's very crucial in case of pediatric case. So approaches would be the two types. Implement IOL with power that are expected to be required in adulthood. Hyperopic spectacle by decreasing power. So basically means the if child grows, then definitely IOL power should be decreased. So that's why we have to implant IOL power that are expected to be required in adulthood, not like required at a particular stage or like 2 years old or 6 months old, whatever. Aim for emetropia at the time of lens implant to become progressively more myopic and require secondary IOL person. So that's why aim for exactly emetropia is always not that good concept, but yes, it's dependent upon surgeon to surgeon. So choices of dioptric power in pediatric case, if child is less than 2 years, then biometry we have to decrease 20% of length. So basically means under correcting or using the axial length like 21 mm, like 22 diopter, 20 mm like 24 diopter, 19 mm 26 diopter, something like that. Okay. If child is between 2 to 8, then biometry by 10% we under correct, and if child is greater than 8, it's same as adult. So these are some guidelines from this reference. So problem in eyes with silicon oil. What happens in the eye with silicon oil? It's very important. Actually, obtaining an accurate axial length measurement with an ultrasonic biometry is very important. But in the particular case, so 980 meter per second speed for silicon oil versus 1532 for the vitreous. That's why the speed varies a lot. So 11.39 is used for the phakic eye filled with the silicon oil vitreous cavity, and 1052 for the phakic eye filled with oil. So that's why the speed we have to go to setting and change the speed. So if sound velocity is not correct, then what could be happen? Then error, like see, it's very huge error, isn't it? 3 to 10 diopter error. So another good way to measure whenever I use a silicon oil is I'll master. So there is no there will be no problem. But with sound, yes, there will be problem. So oil filling with the vitreous cavity acts as a negative power lens, and when biconcave IOL is implanted, this is the game of the index change, isn't it? I've already told you that whenever this is a lens, if the index n s minus n, isn't it, divided by r, if the difference between these two media is greater or lesser, then there will be definitely power change in the second surface of the lens. So that's what this line wanted to tell. So after coronary refractive surgery, what happens? There are three errors. So it's instrument error, because measurement at 3.2 mm zone of the cornea, because that zone is flattened by the refractive surgeons, isn't it? If myopia is, so that's why it's overestimated the corneal power. So and there are high chances the so-called topography are better, and index of refraction error. So basically change in LASIK and LASIK eye, the flatten the anterior surface but not the posterior surface. That's why it's very important. RK, proportional equal flattening of both corneal surface. The overestimate the corneal power by 1 diopter for every 7 diopter of correction is obtained. That's why the regular formulas are not better, and that's why in this particular case corneal topography is better than definitely what do you call keratometry for measuring corneal power. And the formulas error also there. So with the exception of Haggis, all modern formulas using axial length, K reading, inferior position, IL post operative. The anterior chamber depth this dimension do not really change in the eye with proportional with a much flatter K. So basically, in case of refractive surgery, you have to know about the new formulas and you have to implement the new formulas. Like new formulas are very available. I have seen in Almaster 700, yes, definitely. And there are other instrument too, which is recent instrument where newer formulas are implemented, and I have one slide for that in last. Okay, I'll discuss about it. So see, this is the circumstances and choice of the formulas that I have taken from this biometry intraocular lens from iWiki by Sahad EHF. So these are the common guidelines. See, axial length less than 20, Holliday second and offer Q. 20 to 21, 20 to 22 offer Q, and 22 to 24.5 SRK offer Q on Holiday. 24 to 26 Holiday is first. Greater than 26 SRK. Myopic Classic Haggis L, and piggyback Holiday's refractive formula. So these are the common reference, which is very good reference, and I suggest you to go there in iWiki and read this paper, which is very good paper. Okay. So new formulas. What are the new formulas? And I'm just this is the slide. The most problem. This is last slide. So I'm going to talk about four new formulas utilizing Holiday 2 formula. When Holiday IL constant program performs a complex calculation of the for the surgeons and throughout availability HIC is not widespread. I don't know about much about Holiday second formula, but yes, these three formulas and new formulas very useful. Porcelain formula uses the preoperative refraction and the lens thickness to improve accuracy. So I have seen this formula in one machine. I don't remember that machine's name, but yes, Porcelain formula. Barrett's second universal, a new versions based formula. It's based on the versions. Utilize 5 variable to greatly improve the post cataract surgery refractive outcome over older formulas. So that is another good formula for new formulas. So Hill RBF formula powered by artificial intelligence, and also shows the great promise to optimize the refractive outcome. So these are the new formulas, so I think you will go and search about these formulas and understand. I have also taken these formulas, these things from this paper from iWiki. Okay, so I think this is it. And today's video is more than 30 minutes. Okay, these are the reference, and these are the books like ophthalmic ultrasound and cataract surgery and complications by Nomans, and IL surgery by this Stephen, and this iWiki paper, and Kansky definitely, Wolf anatomy definitely, Ianov definitely. These are the references for the today's video. Okay, I think that's it. Okay, bis dann, tschüss.